Good morning. Welcome back to MPHA's 2022 annual conference. I forgot to introduce myself earlier. I'm Heather Drake, the Membership and Engagement Director with MPHA, and I am pleased to moderate this next chunk of sessions here, starting with the evolution of harm reduction services in rural Maine. And that will be presented by Ashley McCarthy, who is a program coordinator at the Healthy Community Coalition. And we're happy to have you here, Ashley. So I'll turn it over to you to begin your presentation.
Great. Thank you, Heather. So good morning, everybody. And I want to thank everyone for your interest in learning about evolution of harm reduction and services in rural Maine. This is definitely newer to us as well, but we are really excited to show our progress and just share some kind of things that we've done that have helped really create this great program in this area. And I wanted to put this date and then mark it to like 1980 or 70 or something, because I know all of you out there probably know that seems like the further you go up Maine, it's like you're going back in time when it comes to, you know, people's thoughts on harm reduction and understanding of substance use disorder. So that's what a lot of people, including one of our sergeants that moved up here, said, geez, it's like coming back in time. Up in Maine, different from Portland area. So let's get started. So I've got my disclosure here. Presenters have nothing to just disclose with regard to commercial relationships. And so our learning objectives today, we're going to demonstrate an understanding of the role of community partnerships in the development, implementation, and advancement of harm reduction services, including mobile clinics in rural communities. We're going to identify three key strategies effective in advancing harm reduction services in rural communities, and also list 4 components necessary for a successful rural harm reduction program. And you can see our little free Narcan sign. That's what we put out in front of our mobile health unit, either right in front of us or by the road, whatever makes sense where we are. So I wanted to start with just a little bit of background about Franklin County. So we're probably all quite aware of this, but in Maine, there are more overdose deaths and car fatalities. In 2021, there was 153 car fatalities and 636 deaths from overdose. From January to July in 2022, Maine has reported 5,852 fatal and non-fatal overdoses. 69 alone were in July of 2022. Franklin County has seen 9 reported overdose deaths in 2022, and I made the reported italic because we do not really have a good reporting system here in Franklin County. That's something that we've been working with some of our community partners, like law enforcement and our local North Star, which is our emergency medical system, to devise a way to get this more of an accurate number. I say that just because I know I did a similar presentation, and I looked back from August to now, and there was 2 obituaries in our local paper that had reported that they had an overdose death. And during our week at the Farmington Fair, we actually had 2 non-fatal overdoses at the fair, and in the same week, somebody passed away from an overdose in Rangeley. So, and that's just from August to September. So you can see a lot more is going on, and that's just reported, right? So those are the numbers that we actually hear about. So that's kind of one of the things that we're working on here too. And I'm sure we all are, across Maine, is trying to figure out, the depth of the problem. So there is a notable cultural distinction among social classes and deep-rooted generational poverty across the region. I'm sure a lot of places see that, and then of course, those additional social determinants of health, like isolation, inadequate transportation, childhood trauma, and adolescent hopelessness, all feed into some of the substance use disorder issues that we have. And economic hardship is one of the region's most critical issues. We had one of our paper mills in Jay, one of our last standing paper mills, is closing, and I think that 200 people or so are going to lose their jobs, and that's just been continuing over time. That people, all these these thriving businesses are going away, and people don't have as much. So it's adding to that that isolation and poverty. And then, of course, on top of all those things is extremely limited services and treatment programs in Franklin County. So we are very limited. We don't have any inpatient programs. So a lot of people, on top of the transportation issue, have to if they want an inpatient treatment, they need to go to Augusta, Waterville, Portland, and those types of places. And that's even if they're accepting and then have insurance. So just a little bit of history of where we were at Healthy Community Coalition to how we got here now. I won't take too much time on this. It's pretty wordy. But there was a, it was kind of through a group that met, there was an issue that came up that there's a lack of medication assisted treatment providers in Franklin County. I think there was only 2, maybe 3 people that were actually prescribing medication assisted treatment. In 2016, we created the Race to Recovery Consortium, and that was established through the Maine Health Access Foundation, MEHAF, with the grant, with the goal to increase MAT providers in Franklin County. And RACE stands for Rural Addiction Care Expansion. And so I will talk about that group a little bit more coming up. But this group that meets at monthly is crucial in all of the work that we've been doing. So we started there, very small, trying to get more providers, which we were able to, which was a success. We've got more MAT providers in Franklin County. In 2018, we went for a HRSA RCORP planning grant to identify more gaps in services in Franklin County and to create a plan to fulfill these gaps. And then that grant had led to in 2020, we were awarded the HRSA RCORP implementation grant to increase prevention, treatment, and recovery resources and services in Franklin County. And just recently, we were awarded a systems improvement and innovation responsive grants, which is SURG through MEHAF as well. So again, we kind of made full circle back to MEHAF. And that was to expand harm reduction services through an already existing mobile health unit that we have here at Healthy Community Coalition, including a syringe service program. And then in 2022, Maine Health was awarded a SAMHSA grant. So not us in particular, but we are part of Maine Health. And that was to expand, again, mobile harm reduction services in rural Maine. And HEC is a partner in that initiative. And then kind of just to give you an idea of kind of the Race to Recovery stakeholder group and why it's so important to have that when it comes to getting your harm reduction approaches out there in the community. So just the folks that are included in that are us, Healthy Community Coalition. We've got local law enforcement, emergency medical services. We have MAT providers and counseling agencies, people in recovery, people in long-term recovery, school representatives. We have town and state officials, and then just guests from around Maine that are interested in the topic that have kind of joined us from here and there. So you can see, I mean, this meeting is well attended, and we've got many different sectors that all meet with the hope that we can, solve some of the problems that we have in Franklin County, decrease deaths, increase access, things of that nature. So just the consortium expectations, we do meet monthly. It's funny because even on the winter months, I said, you guys want to take a break and not, for Christmas or whatever and holidays, and people are like, nope, we want to meet. So it's very well attended. We do discuss current treatment options in Franklin County. We still have that goal to work to increase MAT providers, just because there's always turnover, people come and go. So that's always part of the plan. Explore and implement pathways to treatment and or recovery services. And it really, one of the great things about this meeting and this partnership is it does give partners an opportunity to discuss overlapping issues among sectors. So my example here is there was at one point that somebody got pulled over and they had I believe their Suboxone on them, but it wasn't in a container with their label on it. And so the law enforcement had taken the person's medication, which they of course depend on. And so one of our MAT providers said, well, why would you take that? And law enforcement was like, well, we don't know if it's theirs. We need to take it. So it really, from then on, our MAT providers make sure that they give that person they talk with their patient and say, hey, if you're going to have your Suboxone in your car, you got to make sure you have, proof that it's yours. So that they've really created different ways of making sure that they're giving them a little piece of paper that they can keep. I know some of our providers give a little red bag with naloxone in it, and then some people keep their Suboxone, and they also keep their prescription in there. So some of these problems that we see that, happen in these different sectors that would really get ignored and just keep on going the way they are solved at this meeting. And so where are we now? And this was just a little, oh, actually, I just wanted to, I just wanted to go back just for a second to acknowledge the picture on the right of your screen. We worked with some people that are in long-term recovery and affected others and asked them to do a photo voice project, which is to take a photo that really means something to you, whether it kind of expresses harm reduction or recovery or substance use disorder, really to help to share with the community and help people understand, what folks are going through through photos with a small caption. And this person, wrote, "Do not hate the addict with the disease, hate the disease. With love and support, they can grow and blossom and flourish." I can't really see because my line's on the side here. I don't know if you can see me moving this or not, but this was submitted by a loving mom who loved and supported a daughter with substance use disorder for many years and is now loving and supporting the blossomed and flourished daughter that has been abstinent for more than 3 years. And that was a couple of years ago, and I know that she's still doing well. So I just wanted to share that because these are some pretty neat photos that folks took. So I can move this back. I don't know, can you guys see me doing that? Moving that, okay. So where are we now? So community partnerships, which you'll hear me talk a lot about throughout this presentation, creating those partnerships is huge when it comes to doing anything in the community, especially when it comes to a controversial topic like substance use disorder. We have naloxone access and program expansion. We give naloxone out here, obviously at Healthy Community Coalition through our mobile van, and then here, but we also help. We've helped some different programs launch at the emergency department, at the jail, where they're giving out naloxone as well. We have a substance use navigator. It's actually an MA that's embedded in one of our practices. And so what she does is if there is somebody who is released from jail or somebody in the ED presents with an overdose and they're offered MAT treatment and they get started, that referral goes to our substance use navigator. And she is trained to get the person into an MAT provider that hopefully works for them. It's tricky in this area, but within a few days to make sure that that person's medication is kept up with, and so that they're not going to have a lapse. And then from there, they're connected with different resources that they need. We do have peer recovery coaching through Kennebec Behavioral Health that we partner with on a daily basis. We have our mobile harm reduction services, which the kind of the meat of this presentation, and I'll get to in a minute. I kind of mentioned a little bit about our emergency room rapid access. So if folks do present at our ED, they can and will be offered medication assisted treatment and then sent to our substance use navigator. Will that kind of take them under their wing and make sure that they have everything they need to continue treatment. Stigma reduction, which we'll talk a little bit more about as the presentation goes as well. Which is huge everywhere, not just in Franklin County. I know it's a huge issue everywhere. Franklin County Jail. So we worked with the Franklin County Jail. They now give naloxone out to every person that is released. They also offer an MAT treatment program where if somebody that lives in Franklin County presents and would like to start medication assisted treatment, then they can in the jail. And then of course, like I mentioned, that when they release, that referral goes to our substance use navigator to continue treatment. We do offer education for populations at risk of opioid overdose. So we go to the jail monthly and talk to inmates about harm reduction services. And because of COVID, it's been a little tricky, but we do talk to some of our substance use groups that go on at different agencies throughout Franklin County. And then of course, increased MAT providers and services in Franklin County. So I'm sure that all of you are pretty well aware of what harm reduction is, but I always like to just go over it just in case. So harm reduction refers to policies, programs, and practices that aim primarily to reduce the adverse health, social, and economic consequences of the use of legal and illegal psychoactive drugs without necessarily reducing drug consumption. Harm reduction benefits people who use drugs, their families, and the community. So whenever I do this presentation out for folks, I start pretty basic with even just things like wearing sunscreen. You're exposing yourself to sun, you're at risk, use sunscreen. Bike helmets, those are all ways of doing harm reduction. And then we kind of move into, the bigger things like what we offer at our harm reduction van. And you'll see on the photo on the right, these are some of the things that we offer. The recovery first aid kit, that's where we actually put the naloxone in. for folks and anything else that they want in this little red bag. The little red bags have actually become kind of a staple item for folks. It's really becoming a thing where people know what to look for because it's given out at so many different places through the ED. We have practices that give out the recovery first aid kit. We give them out on our mobile harm reduction van. We actually have a program here in Franklin County where every new mom at Franklin Health is offered and encouraged to take naloxone because we know that new moms are at most risk or one of the most at risk populations of overdosing. And a way of kind of reducing that stigma was to offer it to every new mom. And this is a really neat program because the way they set it up, the naloxone doesn't go into their medical record. So if they're trying to keep private about an issue, maybe somebody they know, maybe it's themselves. Next time they go to the doctor, it won't come up on their medication list. So it's a really neat program that they've created, and it really kind of breaks down that bias because everybody's offered it no matter what. You can see we do the HIV and Hep C testing kits. We do have safe injection kits. We have everything but syringes. That's something that we're actually working on right now, is the application to become a syringe service program in Maine. It's pretty lengthy. So that's something that we're working on right now to be able to offer on our mobile health unit. So again, most harm reduction approaches are inexpensive. They're easy to implement and have high impact on the individual and community health. And in a world where there will never be sufficient resources, benefit is maximized when low cost, high impact interventions are preferred over the high cost, low impact interventions. And human rights apply to everyone, right? I mean, nobody gets to decide, who gets the medication and who doesn't. If there's a medication out there to help people, then they have that right. I often hear some presentations, I've seen people Narcan, 10 times, at what point did they just give up? There is no giving up. Human rights apply to everybody. If there's a way to save this person, then we're going to save them, and hope that time is the time that they are able to enter recovery. And we're trying to make as much through law enforcement and through our EMS opportunities for people to enter recovery in those most critical times when they're there at an overdose. So just looking at our mobile harm reduction. So we go out every Wednesday from 10 a.m. to 2 p.m. With expanded funding. There is potential for added times outside of business hours, but that's what we can do right now. You saw a little bit of what we offer, but we offer naloxone, fentanyl testing strips, HIV, Hep C at-home testing kits, needle clippers, safe injection kits. Like I said, pretty much everything but the syringes. We have peer recovery coaches through Kennebec Behavioral Health who join us. We actually have a medication-assisted treatment provider that joins us monthly to help folks enter treatment, who's lovely. She's great. And we also offer regular health screenings. So yes, somebody's coming for harm reduction supplies, but we do also offer blood pressure checks, body composition, COVID testing kits, and if the person needs insurance, if the person needs help finding a primary care, we're going to help them do that as well. And thank you. And so the where we go is Farmington, Livermore Falls, which Livermore Falls is not in our county, but they're a little black hole of services in their county, so we cover them as well. Wilton, Strong, Phillips, and Eustis. And this the map here on your left just kind of indicates where we go with our mobile health unit and trying to access a lot more people in different areas. As you can see, it's a pretty lengthy service area. So we want to make sure that we cover everybody down from Livermore Falls up to Eustis. So kind of the point of us being here is to look at the strategies to advance harm reduction services in rural communities. So, number one, we would say build a recovery stakeholder group and include those in recovery. So this is one of the most important parts, and maybe, there's some of you out there that have done this, but building that partnership with all of the different stakeholders in the community who have a hand in this is really important. And being a recovery ready community and having peer recovery coaches, but then always including those in recovery, or maybe even actively using in those conversations. We can talk all day about what we think that folks need in our community, but we really need to talk to the folks who have lived it, are maybe even still experiencing it, to make sure that we're doing work that makes sense, and we're going to get the biggest bang for our buck and really access those folks who need it the most. Reduce drug-related stigma. So we wanted to get an understanding of the stigma in our community. So we actually, and I don't have the results from this quite yet, but we did give a community readiness survey to folks in Franklin County. We posted it everywhere we could, social media, in our local newspaper, links, to get the community's input about what their understanding of substance use disorder is, what their feelings are about harm reduction, especially as we enter, the harm reduction and naloxone is one thing, but as we move into syringes, it's going to be a new ball game for folks in communities. So we want to make sure that we have an understanding of what people's thoughts are, where we can direct our education, and where we want to make sure we have our mobile health unit at, where it makes most sense to bring it to. And educate. We try to do a lot of social media education, law enforcement. We do some presentations for law enforcement, first responders. We go to some of our healthcare settings on staff meetings and do some stigma education, which really goes over well, and do that and keep it consistent, just because there's such, there's turnover and such. And the more we can work with the groups that are affected by these groups, the more these folks are want to access some of these resources. And go mobile. So mobile care is on the rise. Transportation is a huge issue. In Franklin County, I think it's always the #1 issue. People can't get there. So, being mobile allows people a little bit, it makes it a little bit easier for folks to get somewhere. If we had it right here at HCC in Farmington, the folks up in Eustis, that's about an hour drive, for folks. So it's not always easy for folks to get down and get what they need. So being mobile is incredible opportunity. What's nice about being mobile too is it can be a discrete location. We can park. You can really park anywhere we want. We do call folks to see if we can park there, but it's nice because if we park at a local gas station and just put our sign out, people can come over and see us. Like I said, we do offer other health screenings as well. So it's not always just, this is harm reduction, this is naloxone. It can be different things as well that people are coming in to see us for. And we find that communities can be more accepting when it's mobile. So it's not part of their community, right? So it's not a building in downtown Farmington. It's a mobile van that's going to be there at a location once a month and then leave. So I think communities have a little bit more, they digest it a little bit easier, knowing that it's not part of their community, but we're kind of an ever moving van and we won't be settled there. So just quickly, 4 strategies to a successful rural community health harm reduction program. So again, creating those partnerships, using these relationships to gain trust with the target population. We can go out and do harm reduction all day, but we need to get to the folks who actually need it. And most of the times, even if people are in recovery and they're going to their provider, they still know a lot of the same people. They might be people in their family, they might be friends they're still in touch with, that they can talk to about this program, so that we can gain trust from that population to say, hey, you should go see them. They have what you need. They've clean, we don't have syringes yet, but safe injection supplies, safer sex dispensary, everything you need. And partnerships, bringing services to the mobile harm reduction. So, it's great to have us there giving, these opportunities to folks, but to have these partnerships is crucial, because we can have an MAT provider and peer recovery coaches. And we've heard of a couple other folks interested in coming, like one of our, it's a service in town that I just got this email recently, but she would love to actually come and offer HIV and Hep C testing right on board. So these partnerships create so many opportunities that folks want to come with us and offer to the public. Reducing stigma. I'm going to go pretty quickly here, because so reducing stigma, social media, using engaging messaging, who's sharing the information always matters. So it's great to share the information, but want to make sure that you share in a place where that's getting a lot of traffic, or people that have a lot of influence on community members, right? You want to make sure that people are sharing it, that, it's gonna get out to the people that need it the most and who, engage with that and can engage. So education targeted at specific sectors. So like I said, law enforcement, healthcare practices, local committees, collecting data. This is one of the most important strategies, right? Working with program partners to collect data, going back to those partnerships, creating those strong partnerships that can help you collect the data you need. Data collection can be fragmented and missed. And without data, our data supports funding opportunities for future, programs in rural Maine. So you have to have that data to really support what the need is and what you have and where you've come. So what you've actually already done to show funders that that this is working and why they should fund you. And consistency. So working with partners and creating new relationships, funding opportunities, and results. So just staying consistent. I mean, we've been at this, I've only been here for 4.5 years, but staying consistent, it's slow, but it's I think back to like seatbelt laws, those took forever, but small changes, just be consistent and you'll see results. Just quickly, just going over data, I want to give people a chance to ask some questions. So we do collect data, learning from our target population, how many people are we helping and who, and is our work working? And we have to do a lot of data for our HRSA, our folks, and we've got some numbers that we share with them through the PIMS. We do a narrative and sustainability plan. So yes, we do all this great work, but how are we going to continue it after? And just a quick overview of our harm reduction services. This says June 22 to present. This is actually probably a month or two back, but it gives you a good idea of what we have given out on our mobile health unit, the number of individuals we served, who we're educating and such. And this is a work in progress. So we're collecting even more data than you see here. And I'm going to give people time for questions because I feel like that was a really quick presentation, and you can see pictured. We've got our mobile health unit with our local options liaison, one of our MAT providers, one of our Healthy Community Coalition crew, and then Sergeant Close, who works with the Franklin County Sheriff's Department. So thank you all. Sorry that I feel like I was a little bit rushed, but I want to give people a chance to ask questions if they have them.
Thank you, Ashley. That was a great presentation. I know we struggle cutting these to 30 minutes because each presentation could probably be a day-long conference in and of itself.
Right.
We do have a couple questions. One, I think, might be a quick one to answer. You mentioned that your kits don't include syringes. Are there other places where people can access those?
So I believe that people can technically, just from talking to people, you can go through a pharmacy. I don't think you technically need to have a prescription at every pharmacy. So that's one thing that we have heard here, at least in Franklin County. And I believe you can buy them online. I've actually looked myself a couple times on Amazon, and I'm not sure what people are using, but I believe you can buy them online as well. But that's an issue around funding too for folks. And are they going to do that?
Great, thank you. And we'll take one more quick question. You mentioned that new mothers are a population at risk of experiencing overdoses. Do you have more information on why this is? So could you just speak a little bit more to the why behind that, perhaps?
Yeah. And people can reach out, and I can send you more information. But so women are most at risk. I believe it's the stress of having a newborn. It's the stress of DHHS and those complicated scenarios that can lead to some of these folks relapsing in their addiction. And I think it boils down to the stress. I don't have the data on me, like right in front of me, but if that's something that somebody is interested in, I believe my information's out on this website. So please contact me and I can try to share some of that data that the folks who actually, because we don't do that program. We help with the bags. But they have a great presentation and a lot of information about it. So if somebody wants to follow up with me, I'd love to share more about that program and the reasons as to why new moms are a target.
Thank you. I appreciate it. And we do have another question we won't be able to get to. So whoever asked that, please follow up with Ashley as well. Ashley, thank you so much for being here. For folks participating, please take the evaluation that's linked to in the chat. And we're going to take a very tiny quick 1-minute break to switch over presenters, and we will be back to talk about recovery residencies. So thank you again. Hello, everyone, and welcome back. We have our second presentation in this 90-minute session, so thanks for either hopping back in or continuing to stay on. I am excited to introduce Ronald Sprinkle, who is the Executive Director of the Maine Association of Recovery Residencies, and he will be talking about the role of recovery residences in the continuum of care of substance use disorders. So thank you so much for being with us, Ron.
Hey, thank you very much, Heather, and thanks to the association for having me. You'll see that I've been living one day into the future. So I'm back to the future today. This is the 11th, in case anybody is wondering. Yeah, my name is Ron Springle. I'm a person in long-term recovery from opioid use disorder. I've been working with the Maine Association of Recovery Residences since about the time they started in 2016. Here's some information just about myself, our URL for our website. I also am serving on the Maine Overdose Death Review Panel. We meet monthly and review overdose deaths. There's 16 of us appointed by the governor. And that's quite an experience. If you've ever heard of vicarious trauma, we were warned about it when we first started, and it was a good warning. I do have no conflicts to disclose with regard to commercial relationships. The goals today, and Heather, thanks for starting us out on those, really to learn a little bit about the history of recovery residences in Maine and nationwide, to understand what is a recovery residence and how they fit into the continuum of care, and to learn if they are or are not, by evidence-based studies, improving outcomes from people with substance use disorder, and to understand the role that recovery residences have, and why recovery capital is important, and what it is, and why we measure and study that. So briefly, this is a national a slide about the national background or history of recovery residences. They've actually got a long history where Dr. Benjamin Rush actually created the first, what he called, sober house for the care of the confirmed drunkard. And that was the term in the day. And of course, it was very early America. We only had a handful of states at that time. Little bit later, we learned about the Washingtonian Home for the Fallen in Boston and Chicago, and the Washingtonian House was actually quite a very large residence in Chicago. And then the Martha Washington Home was the first inebriate home for women. So the first women's residence, 1867. Coming more into the current term, we saw in Maine that recovery houses started in Bangor and Portland, the two largest cities then and now, in the 1990s. There's very few survivors in terms of recovery residence operators from that era. It's actually none that we can think of. But in 2011, the National Alliance of Recovery Residences was formed. This was formed by a group of of folks around the country who saw a need for a national standard, if you will, and they developed a set of best practices. Now, that initial set of best practices, which was they call 1.0, is now in the third iteration. So in the last 10 or 11 years, they've gone through some significant changes and improved them. In 2016, a group of recovery house operators in Portland learned about the national group, and they had the same feeling for the state of Maine as the NAR people did for the country. They were concerned about how certain residences were operated, that were sort of just flop houses where drug use was allowed, where there were no standards for crowding, safety standards, no one did inspections. And so they formed this group in 2016, which is now a 501c3. Recovery residences do have, we can describe them a few different ways, but at a minimum, they offer peer-to-peer recovery support. That means one person helping another. They're usually not professional in nature. They follow and endorse the social model of recovery, which does talk about peer support. One day you could be in a recovery house, even if you're fairly new, and you could be the person helping a person with more experience, and vice versa. Let me go back. When MAR, the local group, was founded in 2016, there was only one operator that allowed people who were taking medication for opioid use disorder. We'll call that buprenorphine, methadone, things like that, Vivitrol. Also known as MAT, medication-assisted treatment, which is a term we try not to use anymore, MOUD, medication for opioid use disorder. There was only one of the founding residences that allowed for that. Now that has changed, and I'll get to that in a second. Residents are protected under several laws, including the Fair Housing the Federal Fair Housing Act, and also the Americans with Disabilities Act. Now, local governments must make reasonable accommodations in their local zoning laws for a group that are recognized as having a disability, which is substance use disorder. The social model emphasizes experiential knowledge. They operate via connections between residents. So lived experience is the currency of that connection. My experience in staying sober is the most valuable thing that I have. And in a recovery residence, that's the currency of connection. So all residences are both consumers and providers. It's kind of a unique model. We like to think of recovery houses based upon the model of a single family home, truly a family, which means that they share recovery activities, creates a basic framework for recovery. So that means they'll share house meetings, they'll go places together, they'll help each other get jobs, they'll do chores, they'll do shopping for the house and house cleaning, typically what a family would do. And it occurs in an environment that encourages and supports abstinence. So as I mentioned, NAR, the national group, was founded in 2011. There are 33 states that currently have affiliates, such as Maine. The organization MAR is one of those 33 affiliates, but 6 are pending. So you can see that it's not all 50 states yet, but it's certainly on the way. They put out a code of ethics, the NAR ethical standards, which emphasize the ethical practices. And these are really important because when we inspect and certify houses, we look for violations of ethical practices. When we receive grievances, we're very clear that the ethical standards must be adhered to. They're also involved in federal lawmaking, and we're involved in state regulation. NAR, when they first surveyed the national scene, they realized that not all recovery residences were created equal, and that's certainly still true. So they developed a system of categorization called the level system, 4 levels. And the first level, level 1, is really, I don't want to call it a low level, but it's a low number. And that's typically an Oxford house, which Oxford houses are peer run, democratically run, like they vote on people coming in or being kicked out. But there's no house manager per se. There's no owner. They work under a charter from Oxford Inc. in Bethesda, Maryland. So self-run, peer-run, self-governing, with no paid staff. Very little in the way of services. More of a group of men or a group of women who have sort of banded together for a common purpose, but living under the Oxford House Charter. Then we get to level 2, which are the majority of the residences in the state of Maine. They often have a live-in house manager who may work but receive some compensation in forms of a housing stipend. Residents participate in government, in governance of the house with the staff and the operator. And there is some program structure, and the cost is less usually. The cost is more than an Oxford house, but less than some of the other levels. We get to level 3, and we have a number of those, but majority are level 2 in the state. We have level 3 houses that are more expensive, but they have paid staff, paid house manager, greater structure, and advanced support. They may have a van for transportation. Ashley rightly mentioned transportation is one of the greatest problems for people seeking recovery in a recovery program throughout all 16 counties. It's not just Franklin. And so often the level 3 recovery house will provide some of that. When we get to level 4, we only have one of those now, but 2 are pending. They actually also have a license from the state. So they'll have licensed paid staff. They'll have usually a full-time substance use disorder counselor, like a LDAC or other, or a social worker. They have on-site clinical services, and these tend to be a little bit more money, but they're also paid for by Maine Care. So even though there's a significant price tag, Maine Care will now pay for those services. Very quickly, MAR, that's the group I work with. We have 11-member board of directors, which now originally consisted of all owner operators. Now it's about half and half. The only group in Maine authorized to inspect and certify residences according to the NAR standards. And we have 3 full-time staff and a volunteer board and consultants. Now, this slide is most recent MAR by the numbers. We have 67 certified residences representing almost 690 beds in 11 of the 16 counties. Franklin is bereft, I'm sorry to say, as is Oxford. And we're very interested. There are 2 of our target counties of the 5 left that don't have a house, a certified recovery house. We're interested in starting both a men's and recovery residence in those counties. Bear in mind that MAR does not start houses on our own. We work with people in the community that want to start a house. And you can see the other numbers. I won't go into that, except to say that the total number or percentage of residences now that allow for medication for abuse disorder has gone from 1 to now 78% of those 67 residences. So that's a huge change, very, very, very needed. And I think is due to the decrease in stigma that we've seen among our own operators between that time and now. One of the major things I wanted to talk about was, and this really is from a public health perspective, is the continuum of care, the clinical course of illness and remission. It's very long, as we know, and I think Ashley's point about people continuing to overdose, and there is no limit to that. We don't give up on people. And part of that is because it's a very long course. If we look at the natural occurrence of addiction and recovery in the United States, we see that it's 4 to 5 years between addiction onset and seeking help. That's a long time for a chronic, often fatal illness. We see that there's a period, often as long as 8 years, where there may be some treatment episodes, but a person is unable to obtain sustained recovery. And then finally, after quite a bit of time, often more than a dozen years, that full sustained remission can occur. Of course, it doesn't occur in all cases, but we call that a 1 year with no symptoms of recurrence. And then after 5 years of continuing care and recovery support services, we find that the risk of meeting the criteria for substance disorder falls below 15%, which is just about what it is to baseline in the rest of the population. So that's a long course of history for if you look at the natural occurrence, the natural progression of the disease of addiction. It's not that much different, say, for diabetes or hypertension. If we look at ASAM, the American Society of Addiction Medicine, their continuum of care for addiction, we find something that's pretty interesting. And this is still current. It's soon to be changed, but it's still the current ASAM continuum of care. And you will notice that although there are 5 broad levels of care, from 0.5 up to 4, and they use these decimal systems to describe their intensity, it's kind of a unique system. Nowhere will you see a recovery residence in this continuum. Now, like I said, this will be changing. We don't know exactly when the new ASAM criteria will come out. We think that probably somewhere it'll fit somewhere between 1 and 2, right in here in the middle, for recovery residences, but they've long been accepted now to be useful in helping people to stay sober. So how do they fit into the medical model? Well, we know now that we have, I have another slide to follow this. We now know that we are shifting our paradigm from episodic care. So what is episodic care? That's treating an overdose. That's treating a heart infection. That's treating any urgent care that's a consequence of use. But the medical system is pretty good at that. Have to admit. But what we've not been good at, and I know this from my years as an emergency room doctor, that we don't do very well with the handoffs. I was very pleased to hear the Franklin County Jail is now providing medicine for opioid use disorder in their handoff and treatment in the jails. That's what we mean by continuing care. So if you have to do a jail term in your own care, you can continue to get that while you're incarcerated. And then upon release, you're offered a prescription and continuing services. That's part of what we mean by that. So we have, in terms of treatment, when a person has gone through acute medical detox, I don't like that word. It's really a medically managed withdrawal is the term we're trying to use. I guess I couldn't fit all that language in a little bubble. But when we get through withdrawal and we're stable, we need stabilization services, because without effective treatment, people usually go back to using a drug and then eventually their drug of choice if that's not the first one. We have brief episodic treatments followed by inpatient, some outpatient. But we have now a variety of other modalities that are available to us. We have mobile technologies to help people keep sober. We have peer services, education-based services, recovery community centers now in 19 of our communities, mutual help organizations such as 12-step groups, and now we also have recovery residences, all important to fit into the medical model. This was a slide I was just mentioning. If we look at the episodic care in the very beginning, it's very high level of care, a lot of practitioners involved, costly, with a very specific focus, high intensity, usually hospitalization in a medical facility, maybe even intensive care. But then as someone gets better, that those levels decrease, maybe to a level 4 recovery residence, level 3, level 2, level 1, and they go through a long period of time with the goal being independent, meaningful living in the community. You can enter the recovery residences at any level. Typically, after an experience with medically managed withdrawal, you may be referred to a recovery house that lets you live there full time. During the day, you're going to an outpatient program and then living there nights and weekends, doing that for maybe a month or two, and then staying there for up to 6 months, which is the average length of stay in Maine for recovery residents. What does the research tell us about recovery residents improving outcome? What outcomes are improved, and how long does it take to see those outcomes? Well, a study done by Louis Jason et al. Starting back in 2006 still remains one of the better evidence-based papers that we look at, because they followed people in recovery residence for 24 months, which is a fairly long time. This was in the American Journal of Public Health. And they found that what they did was they took a fairly large cohort and split them into 2 groups. One group received like the usual aftercare, which is after treatment. And the other group received recovery residence assignment for up to 6 months. Well, what does usual aftercare mean? Well, it's what we've known as usual aftercare. So you may go to a 30-day program, you get out, and then you may have a weekly follow-up group and maybe some urine drug screening, maybe individual counseling once a week, something like that. Recovery residence, though, is as I've already described, where it's a living experience for up to 6 months. So they found at the end of this study, after, again, 24-month follow-up, that there were significant increases in the substance use in the usual aftercare. Recurrence of almost 2/3, where only 1/3 in recovery residence situation. Again, at 24 months follow-up. Monthly income almost doubled. Employment was significantly greater, and incarceration fell by 2/3. Those are pretty significant results. This is a busy slide. I can't read it either. I'm sure the audience can't, but you don't have to. This was a more recent study, and it looked at 962 records in what's called a consort program that might fit the bill in terms of doing research about recovery residences. So they looked at a variety of these, and they came up with a group of about 40 that they could use to kind of look at it in retrospective study. So the previous study was prospective. This is retrospective, looking back at the current research that exists. A lot of this was done from the Recovery Research Institute at Harvard and the Brigham. What they found was there was significant evidence for the effectiveness regarding improved drug and alcohol use outcomes, such as we just saw in the Jason study, improved employment, decrease in criminality, and was cost effective. And this is mainly from the Oxford House study, that up to $30,000 annually was the benefit from living in a recovery house. What were the ingredients for better outcomes? Length of stay longer than 6 months. Again, we're at about the national average in Maine at 5.9 months. The residences that were associated with larger organizations, meaning not standalone houses, and we have a number of those, they seem to do better. And that those that encourage mutual aid group attendance, such as AA or 12-step meetings, they also seem to do better. So there were some go ahead. Did you say 8 minutes? Okay, we're on time. We're doing fine. Mixed findings were around PTSD, women-only houses from the criminal justice perspective, and culturally adjusted homes. Those were maybe homes that were specific to Latinos, indigenous, or others. And they found the old literature for halfway houses wasn't that useful. I want to turn to the last major subject of my discussion, which is MAR and recovery capital. First, what is it, and how do we measure it? And why is it important to assess different types of recovery capital? So very simply, recovery capital, the total resources that a person has available to them to find and maintain their recovery. There are fancier definitions, but those are the ones that are important. And that's the most of them that's sort of important. There are three types of recovery capital: personal, which means what are my resources; family and social, what are the resources around me; and community, what is community recovery capital? An example would be having an options program or recovery center in your community. These are those definitions, which I'd like to skip over since I just discussed them. Our challenge is the ability to measure these outcomes. We think that's important, not only for increasing the professionalism and acceptance of recovery housing as essential support, but also to evolve best practices for funders. Ashley mentioned that it's important for their organization as well. I mean, if we had measurements of everybody's recovery capital, we would be able to compare a men's house to a women's house, a house that allowed MAUD to one that didn't, a house that was specific to indigenous peoples and one that wasn't, to see if there are things that we can learn from what the practice of one residence is doing versus what another is, and make improvements. Recovery capital assessment is asking a bunch of questions, and we do it periodically. Now, I didn't want to put up the 50-item questionnaire which we're using, but instead I put up the 10-item question, which is more of a public health instrument or a survey called the BARC 10, Brief Assessment Recovery Capital. That was from Dr. John Kelly at Mass General. Simply yes or no questions. There are more important things to me in life than using substances. I'm happy, in general, I'm happy with my life. I get support from friends. I take full responsibility for my actions. They can measure these things as milestones in recovery and come up with a score. We come up with a more sophisticated score using the 50-item recovery capital scale. And we measure those at day 1, day 45, and day 90 to see how a person's recovery capital has improved. And I say improved rather than changed, because we almost always see them improve from living in a recovery house. Very little, I don't think we've ever seen one that's gone in the other direction. And one of the things that I know we have a lot of medical professionals listening today, and this slide was actually created for another presentation to specifically physicians at UNE who are interested. But there are things that you can do in your own medical practice. You don't have to be a physician. Any provider can do this to expand your professional recovery capital. Think about what you have laying around the office. Do you have a subscription, a free subscription to Journey Magazine, which shares these stories? Do you have recovery literature? Do you post events that are going on in the recovery community? Did you know that September was Recovery Month, that the 31st of August was International Overdose Awareness Day? Do you mark your patients' time in recovery when milestones occur? I know when I go to see my internist, he says, Ron, you've celebrated X number of years of recovery. That's great. How's it going? Are you still working with your sponsor, going to meetings, or helping others? Those are important questions that you can ask that not only indicate that you know about progress in recovery, but they're helping to mark the milestones that your patients are reaching. Are we out of time? Acknowledgements. Just want to thank these people for their help and resources that are available on the slide deck. These are specific to Maine, so that you can check into the OD Maine app or OD map. There's several don't use alone maps, the options program, Maine Data Hub, and others. And I have references and ask for any questions. I hope we're on time.
Thank you, Ram, so much. That was a great presentation, and I have to admit, a topic that I wasn't that familiar with. So I appreciate it, and it sounds like you're having lots of success. We do have a few questions that have come in from the audience, so I will start with a question about waiting lists for recovery residencies. Do they exist? And if so, what recommendations do you give for those people who must wait?
So that's a really excellent question, and I'm glad that was asked. So each house maintains its own waiting list if they have one. Some don't. If you go on our website now, you'll see a link to find a recovery residence, and we now have the capability for each of our members to indicate if they have beds. There's a bed availability feature on the website. MaineRecoveryResidences.com is pretty simple. It's right on the splash page. Find your residence. So most of them keep that updated. We don't do that for them. They have to do it, obviously. We find that at any given point in time, about 20 to 25% will have an opening. They're very full, 90% occupancy. We need more in the northern counties. We have tend to have more in Cumberland. And Penobscot now has about a dozen, 12 or 13 residences in Bangor and Orrington. But you can look on the website and you'll be able to find availability or make a phone call if there's one you're particularly interested in. They'll get right back to you.
Thank you. And we'll take one other question that's come up. Do religiously affiliated residences participate in recovery residencies? And if not, what are their challenges to doing so?
So they do. We're pleased that one of our original members, Friendship House in South Portland, their director, Herb Blake, has served on our board all this time, continues to serve the Transformation Project, which is in Westbrook. Also, there's a residence also in Penobscot County, well, no, Hancock, I'm sorry, Hancock County, which serves Christian-based programs. There's an Indigenous program, now one going on two in Penobscot County, both in Millinocket and the Men's House in, and I say religious because they're more spiritual based, but as opposed to Christian based. But there's several, and they do very well within our organization.
Thank you. And I think we have time for one last question. What type of barriers do formerly incarcerated individuals with criminal records, specifically felony records, encounter when seeking your services or these services?
Really good question about, we receive a large number of referrals from the State Department of Corrections and from local county jails. The felony record is not a barrier to recovery, since we as a society have criminalized addiction. Most people with addiction have some sort of criminal record. I mean, that's just the facts. So that is not a basis for barring entry. There are some exceptions, and the exceptions are around sexual crimes and arson. And you can understand that, why that could be a barrier. So those are the most difficult cases, but all the other ones really are just sort of trivial.
Thank you. That's really good to hear. And we did that perfectly. We are just time for the end of your session. So I want to thank you so much again for joining us and for the great questions that folks asked. Again, we'll be taking a very quick 1-ish minute break as we transition speakers, and then we will be right back to talk about recovery outcomes and policy attitudes. So we'll take that break and we'll see you in a minute.
Thank you.
Hello again, everyone. I'm excited to introduce the third session in this part of our conference. We are joined by Michael Delorge, who is a third-year student at the University of Maine, and he will be talking about his work in life in recovery in Maine, recovery outcomes and policy solutions to the addiction crisis in Maine. So thank you so much for being with us, Michael.
Hi, everybody, and Heather, thank you to you and the association for having me. Again, my name is Michael Delorge. I'm a junior at the University of Maine studying biology and political science, and I'm here today to talk to you about the group project that I worked on last year as my political science capstone in the Department of Political Science with a community stakeholder to look at recovery outcomes and policy solutions to the addiction crisis. So, as many of you may know, the Maine drug deaths have been increasing each year due to many factors, including the rise of fentanyl, the COVID-19 pandemic. But this chart kind of shows you where we are in the state with drug deaths in the past couple of years. However, not only are drug deaths increasing and fatal overdoses increasing, but non-fatal overdoses are as well. So this chart here on the right shows you the amount of non-fatal overdoses in the year 2021 compared to those that were fatal. So this kind of shows that fatal overdoses might not even be the best way to look at the epidemic of substance use disorder plaguing the state at the moment. In 2021, only 6.7% of reported overdoses were fatal. The rest were non-fatal. So what can be done to save lives in Maine and address this crisis? My group at the University of Maine thought that the answer was promoting recovery. So we allied with the Maine Recovery Advocacy Project, which is a grassroots network of Mainers working to mobilize and advance smart recovery policies in areas of justice, access, and connection. This past legislative session here in the state of Maine, MERAP helped pass 15 pieces of recovery legislation and harm reduction for those in the state of Maine. So a little bit about our collaboration with the Maine Recovery Advocacy Project. I was part of a capstone course, a year-long course at the University of Maine with other undergrads, and my group got together and decided that we wanted to do something with substance use policy here in the state. And the mission of our course, as it says here, we were tasked with addressing the fundamentals of community-based engaged policy research and research methodologies that can help us better understand local policy problems. Targeted solutions required a targeted approach And we plan to do that with a partnership with the Maine Recovery Advocacy Project to address the substance use crisis in our state. So this was our team. We had 5 undergrads, and we partnered with Courtney Gary Allen, who is the policy director for the Maine Recovery Advocacy Project, under the advisement of our professor, Dr. Rob Glover, who is a professor of political science and honors here at the University of Maine. And our project really had 2 aims. The first one was to understand the experiences of those in addiction and recovery in Maine. And our second was to understand the attitudes of those in addiction and recovery on proposed drug policies. And that second aim had greater implications for helping MERAP better tailor their policy goals and initiatives to those they claim to support in the state of Maine, those that they try to help. So a little bit about our methods of this big project. So our survey was called the Life in Recovery in Maine survey. And it was about 75 questions. And we sought and received International Review Board approval in order to carry out this project. And the whole survey was designed using the Qualtrics platform. Everything was anonymous. I'll get into that a little bit more. But first, a little bit about our definitions and how we define recovery, which is a really important definition for some of this work. So recovery, we defined as those in recovery, we defined as people with past histories of substance use disorder who are now in remission or recovered. And we recognize that recovery is a diverse experience, and therefore we sought a diverse representation in our response pool from that experience. We also defined addiction as an active struggle with substance use disorder with one or more legal or illicit substances, ranging from heroin, opioids, marijuana, cocaine, alcohol, fentanyl, crack, methamphetamines, a really wide-ranging list there. So the survey contents of our survey instrument, the Life in Recovery in Maine survey, had 4 parts, each to address those 2 aims that I've mentioned previously. And I'm going to break down the rest of this presentation between those 2 different aims. But parts 1, 2, and 3 of the survey sought to replicate a 2013 study by Faces and Voices, which was a study analyzing the experiences of recovery nationally. Parts 1 and 4 of our survey researched the policy attitudes of those in the recovery community to better serve MERAP and other advocacy organizations in the state advocating on behalf of the recovery population and the addiction population. So in terms of our distribution methods, Courtney Gary Allen was very integral to our recruitment and distribution of our survey to reach the recovery community, as myself and 4 other undergrads at the University of Maine couldn't have done this project without her. So our survey methods for distribution included email, radio show recruitment, and word of mouth. So we relied on the recovery community to pass on our survey. We worked with policy groups, community stakeholders, the Maine public health community, state lawmakers, and the general public. We even went on a radio show to help recruit as well. So that was neat. So methods aim 1. So how did we understand the experiences of those in active recovery and addiction? Well, we asked our respondents about their experiences with 48 specific life circumstances, both in active addiction and in active recovery. And all of these different life circumstances were grouped and analyzed into categories. So we asked people about their experiences, both in recovery and addiction for health, family and social experiences, work and education, legal, financial, and what we called unique addiction experiences. We also asked people about the substances they used, the levels of the amounts of substances they used, and also their length of recovery and some of their recovery habits. Those were all asked. So what did we learn from this? Well, here is a chart that shows some of the responses that we gathered regarding health experiences, comparing active addiction to active recovery. So red highlights experiences in active addiction, blue for active recovery. So this, I hope you can see my cursor here for Plan for the Future. You can see nearly twice the amount of people in active recovery reported planning for the future as compared to when they did in active addiction. So you can see all of these different circumstances that we asked for the health category. Each one of these improved in recovery as opposed to addiction. So we asked about 48 specific life circumstances. 4 of those 48 showed that life in recovery failed to improve as compared to active addiction. So those were loss of professional or occupational license, restored professional or occupational license, got off probation, and regained driver's license. Each of those showed a marginal decrease in recovery as opposed to addiction, which were 4 interesting outcomes that we really did not expect. So just kind of summarize these findings. Life in recovery is significantly better than life in addiction in almost every single aspect. Of those 48 specific experiences we analyzed, recovery life was found to be better for 44, which is very significant. Life in recovery failed to improve in 4 areas. It's hypothesized that these outcomes show the toll of addiction, which we think casts a powerful shadow on a person's life lasting well into recovery, which kind of just shows how powerful recovery is on the rest of a person's life. But we really will need some further analysis to better understand this result, to do some statistical significance tests and whatnot. So our second aim of this project was to understand the attitudes of those in active addiction and recovery on proposed drug policies to better help MURAP and other advocacy organizations. So to do that, the survey asks respondents' attitudes on 13 different proposed policy solutions. So examples of these, many of which were actually taken from the last legislative session and bills that were introduced then. So some examples are creating a Maine recovery ally license plate, expanding recovery community centers to every Maine county, establishing medical detox services in every Maine county, creating an overdose prevention site in Portland, Maine. And I'll get into a few more that we asked a little later. So some results. So one question we asked was people in recovery in Maine's position on expanding recovery community centers to every county in Maine. You can see that the recovery community was very, very supportive of this policy, with nearly 87% of that population agreeing. And the result of this was actually that LD 488 was passed by the legislature and signed by the governor to do just that, with the backing of the recovery community in support of that policy. And we were able to quantify that for the first time to help some of the testimony that was given by various stakeholders at the State House. Another piece of legislation that was passed was expanding the Good Samaritan law here in the state of Maine, which many of you are probably aware of. And that was also passed by the legislature, and we were able to get some results on that, where 87% of the Maine recovery community was also in support of that policy, with very few disagreeing or showing opposition. Maine recovery, people in recovery's position on changing personal possession of small quantities of drugs from a criminal offense to a civil offense, 84% of the recovery community in Maine was in support of that policy. And some recent data from our advisor on this project, Rob Glover, with one of his colleagues doing some separate research on registered voters in the state of Maine, showed that 74% of registered Maine voters supported decriminalizing low-level nonviolent drug offenses. So I wanted to include that just to kind of contrast that figure from the recovery community at large, that Mainers are very supportive of decriminalizing low-level nonviolent drug offenses. Next, we asked the recovery community's position on creating an overdose prevention site in Portland, Maine, where individuals can use drugs in a safe and clean environment staffed by trained professionals. You can see that there was slightly more opposition to this policy, where 11.4% of the Maine recovery community survey disagreed. So what did we find? The Maine recovery community is strongly in favor of the policy solutions that the Maine Recovery Advocacy Project is advocating for. Two policies proved more controversial than most. One was creating an overdose prevention site and a safe use site in Portland, Maine, and also allowing family members to involuntarily commit loved ones to treatment showed quite a bit of opposition, with only 53% of the Maine recovery community supporting that policy. And we took those findings to MIRAP and we're collaborating on some further analysis on that policy as well. So implications, some of the policies that we asked about, here are some results. The Maine Recovery Advocacy Project passed the following legislation with support of the recovery community here in Maine. An act to ensure that path to recovery for persons affected by opioids, using money obtained through litigation against opioid manufacturers. That's another one I hadn't mentioned, but that also garnered a lot of support. And lastly, LD 1862, LD 488, and LD 1175. So some key takeaways from our project. The recovery community is in large support of policies that center recovery and harm reduction here in the state of Maine. And life in recovery is much better than life in active addiction by significant margins. Next, further analysis is needed to understand the mechanisms behind these results, including significance, statistical significance tests. And the recovery community must be consulted in the policy process. Their lived experiences, both qualitative and quantitative, provide valuable perspective to influence the most effective policy change. And past research has really neglected this community. And as such a small, tight-knit neighborhood here in the state of Maine, it's absolutely imperative that this community be consulted in starting to further understand how the dynamics of substance use play out in the state of Maine. Further research is needed by different stakeholders to better understand the lived experiences of those in recovery here in Maine. So what comes after the Life in Recovery in Maine survey? So one of my peers and I are undertaking some separate projects here in the state of Maine to kind of understand recovery a little bit more. But due to the research design of the Life in Recovery in Maine survey, such as time, scope of our project, IRB approval, the Life in Recovery in Maine survey was limited in what it could analyze. Further analysis is needed, as I've said a couple different times. So 2 future projects are kind of analyzing parts of this data to better understand that. So I'll get into 2 of those here. So one of my peers, Jacob Chaplin, he's another junior at the University of Maine studying political science, is beginning the Life in Recovery While Incarcerated in Maine project. His goal is to provide the incarcerated community with the same opportunities that the LIREM survey previously gave those in recovery in the state of Maine, for this time for the incarcerated community. So he's asking, what factors facilitate or hinder pathways to recovery for incarcerated Mainers? What are the policy attitudes of the incarcerated recovery community? And how do the lives of Mainers in recovery differ from those in recovery while incarcerated? So these were questions that we really wanted to ask last fall when we began the survey design, but now he's tackling them in another independent project after our survey could not analyze these, because they're very, very important to understand. So my project is researching social determinants of long-term recovery success. So I'm actually analyzing data that we gathered from this survey to better understand how individuals' demographic information contributes to their success in recovery. And that kind of has a social determinants of health element too, for those of you familiar with that term. So my hypothesis for that project is that recovery success increases with increased geographic access to recovery services and an increased sense of belonging with a community. So that's another large implication that this greater survey could have as a result of that. Lastly, I'd like to thank our professor, Rob Glover, for his mentorship on this project, Courtney Gary Allen and the Maine Recovery Advocacy Project, the Maine Recovery and Harm Reduction community, my peers, Jacob Chaplin, Bonnie Snyder, Bryce Andrews, and Sam Ransley, Dr. Alexandra Laudette, Heather Drake in the MPHA's Alcohol, Tobacco, and Other Drugs member section, Bethany Fournier, Jake Posick, and Adam Hartwick. Thank you very much, and I'd be happy to answer any questions at this time.
Thank you, Michael. That's fantastic research, and I think ties nicely with the two other presentations we had on harm reduction and recovery residencies and how important those are to the recovery community. So thank you for presenting this great body of work. For folks, just a reminder, please put questions in the Q&A and we'll take those as they come in. We do have 2 questions in the queue right now. The first one might be quick. How long did the project take you from start to finish?
The project went on from the fall of 2021 in September to the spring of this year, 2022. So total, it was about 9 months, the whole academic school year.
Thank you. And I forgot to say this question asker also said, very impressive work. So you're getting lots of positive comments. Their second question is that many of your policy conclusions and recommendations treat the here and now, which is certainly needed. Did you consider policy solutions which will positively impact upstream factors leading to substance use disorder?
That's a great question. We hope that some of our results that will be coming out soon on life in recovery, especially some of the social determinants of health factors, will be able to address some of that. But at the time that we were developing this survey, a large majority of the questions that we were asking were about the upcoming legislative session. So the second aim of our survey is something that could be very easily replicable for future legislative sessions or, future decades if that would be needed. However, the recruitment was challenging. I know people are inundated, especially many of you listening to this presentation are probably inundated quite frequently with different surveys. So yeah, I hope that answers that question.
Thank you. And I'm not sure, given that you're on the more of the research side of this, but if in your conversations and work around decriminalization of drugs, if you believe that will come up in the next session from what you've heard.
I'm sure. The recovery community had a really successful last legislative session, but there are still many policies that they're interested in putting forth this year, especially after the feedback that they received from the last legislative session, that myself and other researchers and different community partners, legislators have all been able to provide them with. So I'm confident that this work is ongoing and will keep moving and adapting for the next few decades, especially as Mainers are more receptive, the data is showing, more receptive to different recovery policies here in the state.
Thank you. And so talking about including the lived experience voice and policy solutions, are there other recommendations on good ways to do that? And considering how impactful it has been including this voice, do you see any replicability or adaptation with including the voices of other communities in policy making and legislative endeavors?
Yeah, I think that's very important. I think that also my peer Jacob's research kind of tries to address that. One of the key understandings when we were going into this this large project was that the recovery community had been largely neglected in a lot of the research on recovery at a national level. And with Maine's recovery community being so powerful and well organized, we were lucky to be able to coordinate with them and tap into their network with their help. So I think that there's a lot of opportunity to us in this work to really understand groups that haven't been understood for a very long time. And I think the state of Maine is waking up to that as well.
Thank you. And two follow-up questions to that. Did you have any difficulty building trust with, getting folks to take the survey and engage? Was there any hesitancy there? And do you have suggestions if others are struggling with that, how to do that?
We weren't faced with too much hesitancy in this particular project because of the fact that we developed the project directly with Courtney Gary Allen, who is a member of the recovery community herself, as well as the policy director for the Maine Recovery Advocacy Project. So she helped us really center this research on recovery-centered thoughts and language, and she helped kind of mediate the discussion between a couple of researchers at the University of Maine and the wider recovery community at large. So I think that future research on this topic for it's integral to have somebody, a member of the recovery community, or strong, powerful relationships with people such as Courtney. I think she was amazing.
Thank you. Yes, definitely important in development of the surveys. And we have time for one last question. So you talked a little bit about Maine having a particularly strong recovery community. Can you talk about what this community looks like in other states and what they're doing to address policy? Did you look at that at all in your research?
No, our survey was only for the state of Maine. We did, like I said, we did replicate part of our survey from a national study that tried to gauge the experiences of recovery and addiction. But to the best of our knowledge, that study and studies like it were never replicated at state levels around the country. So we believe that our survey is the only one like it at a state level for a state-specific case study of the experiences in recovery and addiction in Maine. So personally, I can't speak to recovery communities of other states in particular, just the one in Maine that I've had the ability to work with.
Great, thank you. And again, really important that you're doing this work and taking it on and including this voice, especially in policy making. So I'm not seeing any other questions at the moment. I'll keep my eye on that as I do our wrap up, and thank all three of our speakers and Michael for being with us for this session today. And thanks to everybody for participating. We really appreciate it as we go into somehow it's already lunchtime, our lunchtime break. Just a couple reminders to please take all of the session evaluations. This is particularly important if you want any continuing education credits, so please make sure that you do that. You can find the evaluation for each session in that session's description in the agenda. Please, we have a networking room this year, so hop in there during your lunch break, poke around, get familiar with it, try to find some familiar faces. We will also be using that same networking room for our poster reception, which is at 1:40. So it's great to familiarize yourself with it a little bit if you have time beforehand. And I thought I had one more announcement that I'm forgetting, but we will start again at 12:30. So you've got a nice, hopefully chunk of time to get up, move around, get yourself something to eat, and then we will settle back in at 12:30. So we look forward to seeing everybody again then.